Hello and welcome to this video on chronic heart failure. I'm Professor Anthony Cummins from the Department of Family Medicine at RCSI Perdana. This is the outline of our video. We'll begin with learning outcomes and go through each of these with illustrations from a case history about the salient features of heart failure and its management. We'll focus also for a period on how the diagnosis of heart failure is communicated to patients. These are our learning outcomes. Following the video, you should be able to take a focused history and perform a physical examination to identify the symptoms and signs of chronic heart failure. You should be able to describe in detail the investigations used to confirm or exclude a diagnosis of heart failure. You should be able to formulate a management plan, including drug and non-drug strategies for patients with heart failure. And finally, you should be able to describe the components of chronic disease management in the context of heart failure. Heart failure is difficult to diagnose. It's certainly not a specific diagnosis. It's mainly a syndrome which largely features consistent with left ventricular systolic dysfunction, leading to impaired contractility, with its more common causes as coronary artery disease, the majority, and to a lesser extent hypertension. In a smaller number of patients, 30% maybe, the problem isn't systolic dysfunction and contractility, but diastolic dysfunction and failure to relax the left ventricle. This occurs most commonly in elderly hypertensives with stiff hypertrophied left ventricles because of chronic sustained hypertension. Clinically, heart failure is difficult to diagnose because the features are non-specific, and these features here can be due to a variety of other causes. And also because in elderly patients, these features often coexist along with the heart failure, making not just the diagnosis more difficult, but also worsening the prognosis. This applies not just to anemia and other problems, but also to depression. How do you communicate this diagnosis? The phrase frightens patients, and it makes doctors and nurses equally nervous. Have you seen anybody give this diagnosis? How did they handle it? And how did they respond if a patient should ask, "Is my heart going to stop suddenly, doctor? Am I going to die?" What preparation and support is provided for newly diagnosed patients? How do they plan for the road ahead? What about their family and carers? Reflect now for a moment about how you would tell somebody this diagnosis. What form of words would you use? We have a section on Moodle on breaking bad news, and it may be useful to look at this once you finish this video. There's also a link here to some patient experiences from the Health Talk Online web resource. Heart failure has a poor prognosis. Approximately 40% are dead within a year of diagnosis, and by 5 years the mortality is still about 42 plus. About half of these die suddenly, and most of these sudden deaths are arrhythmic, so they're probably from ventricular fibrillation or ventricular tachycardia sustained. There may also be other complications as shown here. It's a common enough condition and very more common. One of the reasons why it's more common in the elderly is because we have been quite successful in treating acute myocardial infarction. So a lot of elderly people who formerly would have died are now living with damaged hearts. So your average GP with a list of patients of 2,000 would have about 50 patients on their list, would have about 20 suspected new cases a year, of which 50% are confirmed. The quality of life of people with heart failure is very poor, and it's been confirmed to be worse than that of osteoarthritis or diabetes. So this is a severe disease with a terrible mortality, which is now approaching epidemic proportions, particularly in the very elderly. So as students going on to become GPs and hospital doctors, you need to be aware not just of the evidence base for safe and effective prescribing, but also the ethical aspects and communication skills needed when giving this diagnosis of bad news. You can see here very clearly this big blue part of the pie chart, coronary artery disease is the big reason why patients develop heart failure in most parts of the world. The clinical features are difficult to synthesize together, and they include fatigue symptoms and breathlessness, and particularly as the heart failure is progressing, particularly forms of breathlessness such as orthopnea and paroxysmal nocturnal dyspnea. There may be other symptoms also as listed here: nocturia, anorexia, bloating, discomfort, constipation, etc. The onset may be insidious until there's a sudden decompensation from, let's say, tachycardia or atrial fibrillation, leading to sudden breathlessness and paroxysmal nocturnal dyspnea, etc. There may be physical signs of fluid retention, and these are listed here, like basal crackles, pleural effusion, increased GVP, pitting peripheral edema, enlarged liver, abdominal ascites, etc. And there may be something that would also tell you that the heart is enlarged or dysfunctional, for example, displaced apex beat, heart murmurs, a third heart sound, etc. When you're assessing patients with confirmed heart failure and monitoring them, the clinical things you should record are as follows: the blood pressure, their weight, calculate their BMI, check their pulse for rate and for AF, listen to murmurs, look for the GVP, listen for chest signs, and check for pitting edema. The differential diagnosis is very wide because these symptoms, fatigue, breathlessness, and ankle swelling, have a whole range of other causes as listed here. It can be very difficult to tell them apart from heart failure, especially in obese patients. How does heart failure come about? Well, most of them is due to coronary artery disease, and most of that comes from acute myocardial infarction, often anterior infarction, which puts out a lot of the left ventricular contracting tissue, so you develop impaired contractility. But it may also arise from other causes, such as severe aortic stenosis or uncontrolled hypertension, which effectively puts a block beyond the heart, and the heart has to raise its pressure in order to try to get blood through into the circulation. It may also arise not from any contractility issue, but from diastolic difficulty in relaxing because of stiffness in the left ventricle, and this is largely due to left ventricular hypertrophy secondary to hypertension in elderly patients, but you may have other causes as listed here. Occasionally you'll have problems from mitral stenosis and pericardial constriction. These are very rare. Let's look at a case history. This is a 79-year-old man who lives alone. He has hypertension and diet-controlled type 2 diabetes. He smokes 15 a day and has done so since his early 20s. He's come to you now in your GP clinic with 2 months of breathlessness, walking up steep hills, a bit of a dry cough, and fatigue. On examination, his blood pressure is 162/85, his pulse is 82 and regular with no AF. His chest is clear. There is mild edema of both ankles. This is his current medication: amlodipine, 5 mg once daily for the hypertension, and simvastatin 10 mg at night for hypercholesterolemia. What questions do you want to ask? What's a differential diagnosis? What test would you like to do in your clinic? And which would you order from the local hospital? Have a think about these. We'll come back to him later. These are the investigations to confirm or exclude heart failure. The most simple and available one is the resting 12-lead ECG. So what you're looking for here is evidence of previous infarction, Q waves. You're looking for atrial fibrillation. You're looking for left bundle branch block. You're looking for left ventricular hypertrophy. These are all abnormal and tells you that this man has got underlying ischemic heart disease or hypertension. A completely normal ECG would go a long way towards excluding chronic heart failure as the cause of somebody's breathlessness or fatigue. The other test you can do, albeit more expensively, but still becoming increasingly available, is BNP, or brain natriuretic peptide. This is a peptide which is released from the brain. It also is found in the atrial wall. And effectively, it's released when there is atrial stretch. So if there's overload, for example, levels of BNP will be released into the circulation. It's important not just as a diagnostic test, but also as a monitoring tool. in patients with established heart failure, a raised BNP is associated with a worse prognosis. For primary care and family medicine, it's more useful if it's negative or normal. A normal test, especially coupled with a normal ECG, has a 98% negative predictive value. So it's a useful test in primary care to exclude heart failure, whereas it's more used and more useful in secondary care with a sicker population to confirm and monitor heart failure. The ultimate gold reference test, however, is the echocardiogram. So you can look at wall motion, you can look at ejection fraction and calculate ejection fraction. You can look for cavity thrombus, look at valves, and so on. Now, in some countries, this is available to primary care doctors. In Ireland, it's only patchily available. It's available in the UK through direct access, but generally speaking, in other countries, one has to refer the patient to a cardiologist. Now, there are other simple tests that can also be very useful to exclude the often confounding illnesses that can give rise to some of the symptoms. For example, a full blood count for anemia, UNEs for renal impairment, LFTs as a baseline, and a chest x-ray if there's any suggestion of underlying respiratory disease. And then to look at overall global risk, you may want to measure the cholesterol and the total lipids and the blood glucose. NICE, the National Institute for Clinical Excellence in the UK, has released some years ago now a decision support algorithm which more or less just repeats what I've just said. In suspected heart failure, do an ECG and or a BNP. If these are both normal, heart failure is very unlikely. Consider other diagnosis. So this is where the other tests like the full blood counts, chest x-ray would come into play. If they're one or both are abnormal, then you would then go ahead and do an echocardiogram. How is it classified? Well, classified according to cause, according to the type of heart failure, systolic, diastolic, and so on. And the underlying causes, as you know, the primary cause is coronary artery disease, but there may be others. The primary cause of this diastolic heart failure, or heart failure with preserved systolic function, is hypertension. The classification that's used most widely is the New York Heart Association, or NYHA classification. This is very subjective. It goes from class 1 to class 4 in Roman numerals. Class 1 is no symptoms, but perhaps an abnormal ECG or an echo. So an ECG showing left ventricular hypertrophy, or an echo showing that and reduced cardiac contractility and reduced ejection fraction. Grade 2 or class 2 would be breathlessness on moderate to severe exercise, and then this progresses onto class 3, breathlessness on mild to moderate exercise, and finally breathlessness on very mild exercise or even at rest. For example, breathlessness on showering. This is a nice pathway of dealing with heart failure, So you first of all decide if it's possible, if it's diastolic heart failure or systolic heart failure. If it's systolic heart failure, we've got a better evidence base for medications that have been shown to be beneficial. The evidence is not yet there for managing diastolic heart failure, but we tend to use similar drugs. And if symptoms persist despite using the appropriate medications such as ACE inhibitors, beta blockers, and with the addition of aldosterone antagonists such as spironolactone or eplerenone, but if patients persist in having symptoms despite all of these, then you may want to consider referral for insertion of a pacemaker or an ICD. So what drugs are evidence-based for heart failure? Well, effectively, ACE inhibitors, angiotensin receptor blockers, separately instead of or in combination with ACE inhibitors, beta blockers, spironolactone, and more recently eplerenone. Digoxin is not evidence-based in heart failure, and diuretics are not, but they're good for symptomatic relief. So it's very important that you don't just have somebody diagnosed with heart failure and just simply give them diuretics. You must give them these drugs also. Let's go back to our case history. This man, aged 79, comes back to you 6 months later, complaining of increased shortness of breath for about 2 weeks. He's not finding it difficult to climb the stairs. He missed some of his tablets because of a wedding, and he doesn't check his weight because he can't read the scales. On examination, his BP is 112/86, his pulse is 82, his chest shows some basal creps, and his mild pitting edema of his ankles. His weight has gone up over the last 3 months from 76 to 79.5 kilos. His current medication now is ramipril 10 mg daily, furosemide 20 mg daily, simvastatin 10 mg nightly, bisoprolol 10 mg daily, and metformin 500 mg twice daily, and aspirin 75 mg once daily. What action should you take now? How could you assess his medication concordance? Does he need further investigation? If so, where and with what urgency? Let's look at an overall management plan. You can see examples of these on both these websites, Patient UK and the British Heart Foundation. Patients should reduce salt intake and reduce weight if they're obese. They should certainly reduce alcohol, restrict alcohol intake. They should stop smoking if they're smokers and try to take regular exercise. They should watch their fluid intake, especially if the heart failure is severe. They should have yearly influenza vaccination and 5 to 10 yearly pneumococcal vaccination. They should be assessed for depression. This is common in patients with heart failure, and it worsens the prognosis of heart failure. They should get evidence-based treatment as described previously, and may need referral for device therapy. They should be reviewed every 6 months, but more frequently if needed. Each time you should check their clinical state, their functional capacity, fluid status, their rhythm for AF, their cognitive function, nutritional status, their mood. You should also record all the drug therapy, try to check their compliance, inquire about adverse effects, and check their use and ease of creatinine. Here's an example here of a community heart failure program where patients are able to self-medicate with diuretics depending on their presence or absence of leg edema and rise or fall in their weight. It's the same as what I said earlier. So what about adverse effects? What are you looking for? Well, the classic adverse effects of ACE inhibitors: cough. There may also be a rise in serum creatinine, and you may need to stop the drug if it rises more than 25% from baseline. Some people will get hypotension with ACE inhibitors. It's rare if they're given the sole therapy, but if they're combined with ARBs, for which there is evidence in heart failure, but it may lead to worsening hypertension. It may also have an effect on angioedema, hyperkalemia, etc. Beta blockers may cause bradycardia and fatigue. They should be explored in patients at the outset and let them know this may happen and not to be alarmed. But if it persists beyond 3 months, then you should probably withdraw the drug and exchange it for something else. Some patients with severe heart failure may experience a worsening of symptoms with beta blockers, and perhaps these should be avoided in this subset of patients. Diuretics can cause incontinence, and certainly you would never use a powerful drug like furosemide twice daily. Hypotension is another problem, and this can lead to falls in the elderly, and because these patients often are elderly, then the implications for inappropriate use of loop diuretic can be huge. It can also have effects on electrolyte imbalance in cautions with polypharmacy, especially metformin, and monitoring of electrolytes and urea. Cardiac resynchronization therapy and biventricular pacemaker has been shown to be effective in improving outcomes in heart failure, with a 37% relative risk reduction in cardiac death and hospitalization, and a similar reduction in all-cause of death. Similarly, implantable cardioverter defibrillator ICDs in the SED-HEFT study showed a reduce in sudden cardiac death, but no effect on symptoms. Nurse-led care has been developed in various centres around the world, notably Glasgow and Australia, and it showed profound benefits, not just in soft data, but in all-cause hospitalization, heart failure-related hospitalization, and duration of hospital stay for those who are admitted. Telemonitoring heart failure may be useful. I think the jury is still out on this, but there seems to be some reduction in all-cause mortality and in heart failure-related hospitalizations, an improvement in quality of life, reduced costs, and the telemonitor was acceptable to patients. There were some improvements in prescribing, patient knowledge and self-care, and NYAJ class also. Self-care is very important for somebody with such a severe chronic disease. It's important that they understand why they have to have a balanced diet, why they have to reduce sodium or salt in their diet and limit their fluid intake, why they need to monitor their weight each day, and why they should always have a list of all the current medications. They should know at the outset what side effects they could experience, for example, breast tenderness with spironolactone, fatigue with beta blockers, and any specific follow-up visit instructions that may depend on the particular circumstance. But it's very important that everybody who's involved with these heart failure patients should be in the loop: cardiologists, GPs, heart failure nurses, the practice nurse, pharmacists, and the patient themselves and their carer or family. Finally, here's a summary sheet from the Oxford Pocketbook for PACES 2012 on heart failure. You can look at this at your own leisure. It's also available in the PowerPoint on Moodle. These are references for you to look at subsequently. Most of these are clickable web links. This is the Oxford Handbook, which is available through the library. It's an online source. And this is Quick Medicine, which is an app you can download from the App Store or Google Play Store. Thank you.